All right, well, it's 12:01, and to respect everyone's time, I think we should go ahead and get started. Good afternoon. Excited to have this presentation today. We have a topic in oral health, and it will be presented by Dr. Charlie Arthur, and he is with Morecamp and Arthur Family Dentistry in Rolla. We are very excited for you to be here with us today, and I'll let you go ahead and start presenting. Thank you.
All righty. Yeah, like you said, my name is Charlie Arthur, dentist in Rolla, Missouri. And so just wanted to give you guys a quick presentation on dentistry in general. And I'll try to tie it to as much in the medical field and what would be relevant to you guys as much as possible. But so there's basically 4 years of dental school here for you in 40 minutes. And so let's see here. So if any of you have ever heard me speak, which I can confidently say it's going to be none of you, I like to use a lot of quotes in my presentation. So if you don't get anything out of this, hopefully you'll get some good quotes. And so education without application is just entertainment. And so that has always rung strongly with me, is that hopefully you guys can get something out of this presentation that you can immediately take back, whether it's a little bit of dental knowledge or you can tell with me it's all about patient care. So what I'd like to cover today, a little bit will be on my journey into dentistry and the career path I've taken, dentistry and oral health in general. I'll give you a little bit of dental anatomy, and then we'll go over each kind of stages of life of dentistry, so pediatric, adult, and then geriatric care as well. I'll go through some acute dental problems because that is mainly what you guys might see in the medical profession. And then oral facial pain, really the oral systemic link, and then continuing education. So a little bit about me. I have a wife, Emily, and then 2 kids. So Lucy, she's 4.5, and Graham, he's 3. He just turned 3 last week. And then we have another baby on the way in August. Grew up in Rolla and kind of always enjoyed the small town life, and so knew that I wanted to come back and practice. And so my education, graduated from Rolla High School in 2006, went on to Truman State, where I got a Bachelor of Science in Biology in 2010, went straight into dental school, finished with my dental degree from UMKC in 2014. And then I did my dentistry through the Air Force. And so immediately after I graduated from dentistry, I went ahead and did one of the 2 main general dentist residencies in dentistry. There are either an advanced education in general dentistry is what I did, or there's graduate practice residencies. And the main difference is that a graduate practice residency is more hospital based. And I did that down in Eglin Air Force Base, Florida, which is just outside of Destin. So that was pretty sweet. So then my career path. Right after my AGD, I was a staff dentist in Incirlik Air Base in Turkey, which was kind of neat because it's a NATO mission. So I got to see dentistry and patients from all across the world, some good, some bad. And then after that, I went to the Air Force Academy, where I was the staff dentist there, taking care of a lot of the cadets and staff members. And then when I separated from the Air Force in 2018, I bought my father-in-law's dental practice with my brother-in-law. So it was 2 dentists buying a 1 dentist practice. So in a sense, we had to double the patient base. And while we did that, my brother-in-law and I both split a job at a federally qualified health center in a rural town that wasn't too far away from us. And so I've had a good mix of almost every different aspect of a medical career and different kind of situation you can be put in, except for mainly a hospital. And so real fast, just going through what dentistry is. And so Hollywood has not been nice to my profession. We are trying to move away from just being known as a tooth fixer to maybe just known as a physician of the mouth. And so the American Dental Association, they define dentistry as the evaluation, diagnosis, prevention, and/or treatment of diseases, disorders, and/or conditions of the oral cavity, maxillofacial area, and/or the adjacent associated structures. And here's the real big kicker, and their impact on the human body. And that's where I was mentioned the oral systemic link, and that's kind of what we're really focused on now. And I promise that's the only time I'll read directly from the screen. I know that's not the best. But here's another funny little meme that comes around with dentistry, and I'll leave this up here for you to read. But really, all jokes aside, society will have all kinds of perceptions on your chosen career field, and you have the power to change those. And that's what I work on doing, is changing my patients' views on dentistry, because it's not uncommon to hear from new patients how this is not their favorite place to be, or no offense, but I hate the dentist. And you know, you got to be fully aware, and I'm fully aware that dentistry has hurt a lot of people, both physically and emotionally. So I do my best to help patients not let those come in the way of achieving optimal health. So dentistry is split into different specialties. Just like medicine has subspecialties, so does dentistry. And so overall encompassing is general dentistry. And then you have orthodontics, which is mainly involved with treating irregularities and deformities of teeth and the jaw structure in general, so they can work with growth. They straighten teeth, most of the times with Invisalign and braces. Periodontics, they're involved with the supporting structures around teeth, so the gum and bone, that's their specialty. Endodontics would be the pulpal tissue, or the very inside of the tooth, so they're your root canal experts. Then we have oral and maxillofacial surgeons. They take out wisdom teeth, they do orthodontic surgeries, place implants, all different kinds of aspects. There's cancer surgeons, everything like that. Oral maxillofacial radiology, they would be more likely for the interpretation of radiographs. If there's some pathology, if there's big radiolucencies, whatever is noted there, that's who we can send off to. Oral maxillofacial pathologist, if we need to do a biopsy from one of those radiolucencies, or if there's soft tissue that we're concerned about, that's who we send off to, and they'll give you a report, what the histology is shown, so what they think it is, how you would treat it, and kind of follow-ups. Oral medicine, and so that's the specialty of dentistry that's responsible for oral healthcare of medically complex patients and the diagnosis and management of their medically related diseases. And then you have oral facial pain experts, and that can be anywhere from TMJ issues to rare neurological symptoms that are not of odontogenic origin, so non-tooth related. Prosthodontics, they're usually involved in the major rehabilitation of the mouth. So somebody that's really had a lot of wear or major trauma. They also don't just treat teeth, they can do prosthetics for the eyes, nose, ears, any kind of major, anything in the oral maxillofacial area. Pediatric dentistry, those are our saints in dentistry. They deal with kids. And so, you know, not always get the most behaved children. And so we like to keep those. But if you know, young dentists or young children, excuse me, need care, and, you know, they have a special tool set to allow them to care for people of all ages, 18 and under, I should say, not all ages. Dental anesthesiology, that's more of a newer profession. They just kind of help really anxious patients or patients that need to be put to sleep during their procedures. And then dental public health, and that's they control and help promote health around different communities and have organized efforts for that. So here's another quote for you. Dental health is peculiar. The rich cannot buy it and the poor cannot have it given to them. I can make people more comfortable, more functional, and more attractive, but I cannot make them more healthy. I can teach them how to become more healthy, but whether they remain that way will be up to them. And so Bob Barkley is really kind of the godfather of preventative dentistry. He passed away a long time ago in the 70s from a plane accident, but what he spoke about in the 70s still rang very much true here. You know, it's become more of just a, don't just fix it and then let it fall apart again, but have the patients understand how that's happening. And yes, I can fix it, but if you have bacteria that are eating away at the strongest thing in the body, and I'm filling it full of a weaker material, what do you think is going to happen if we don't solve the underlying issue? So then real fast, and going through dental anatomy. So there's 4 major types of teeth. And so incisors, we think of as the front 4 teeth. And so the 2 front teeth in the middle, those are our central incisors. And then on the outsides of each of those, we call those lateral incisors. So there's 4 on top, 4 on bottom. Canines, so there's 1 in each quadrant. So if you separate the mouth into fourths, you'll have a canine in each quadrant. directly behind the canines are premolars, and so you'll have a first and second premolar usually. The first is right behind the canine, second behind that, and then molars, and so you'll have a first, second, and third molar, and third molars are often referred to as your wisdom teeth. And so this will be an important as far as explaining, especially when it comes to acute pain with dentistry, is understanding the anatomy of a tooth. And so on the right side of the screen, you'll see the external anatomy. And so this is a stained tooth, so it really gives good view of the grooves and pits that are involved in the tooth. And so this is what we call the occlusal surface or the chewing surface of a tooth. And so it has grooves that separate the teeth into these large projections called cusps. And then going into the internal anatomy on the left side of the screen, you'll see that there's basically three main layers of tooth structure. And so the outermost layer is enamel, and that's the strongest, most mineralized substance in the body. It's about 95% hydroxyapatite. And the nice thing about enamel is that when it becomes demineralized from acids and bacteria, we can actually remineralize that. And that's how we remineralize that, is through fluoride. The middle layer of tooth structure is called dentin, and that's about the same mineralization of bone. So it's about 70% mineralized. And the very middle of the tooth is the pulp chamber, and the pulp chamber has all the nerves and blood vessels that belong to a tooth. And so the goal is to catch issues before it gets to the pulp chamber, because that's what causes pain. And you can also see that teeth are actually surrounded by ligaments. And so we call it the periodontal ligament, and that's what attaches the tooth to the bone. So teeth actually do have a little bit of flexure. And then around the alveolar bone, we have the gum tissue. And so real fast, so we can understand surfaces, and this is how we dictate what treatment needs to be done, and in our notes and codes and everything like that is, so facial and buccal would be the cheek side of the teeth, and facial leads for the anterior teeth, whereas buccal is posterior teeth. Lingual, if you think of lingual meaning language, so the tongue side of the tooth, that's on the lower teeth, and palatal, so we have the hard palate on the inside. So on top teeth, the inside of a tooth is called the palatal surface. Mesial, going towards the midline. Distal, going away from the midline, so further back in the mouth. Occlusal is the chewing surface of back teeth, and incisal would be the chewing surface of front teeth. So that's the more flat, kind of biting into things area. And then another thing that helps us when referring to teeth is how we talk about individual teeth. So it's typical for somebody to have 32 teeth. Some have more, some have less. But how we number them is we start on the top right, and that would be your top right wisdom tooth is tooth number 1. And then it goes all the way to the top left wisdom tooth, which is tooth number 16. Then you drop down to the back left wisdom tooth on the bottom, which is tooth number 17. And then all the way to the back right tooth, wisdom tooth on the right side, and that's number 32. And then with primary teeth or baby teeth, and I'm sorry if this is a little blurry, we don't use numbers, we use letters, but we still refer to them as number A, which makes a lot of sense. So we have A being the top right, and all the way to J on the top left, drop down to the bottom left being K, and all the way to the bottom right of T. So pediatric oral health. So this is my daughter Lucy on her first visit. You'll hear everything from when a child should have their first dental visit. If you look up the American Association of Pediatrics, it's the absolute, gold standard recommendation would be within 6 months of the child developing their first tooth. And so really what that comes down to is you don't ever want a child's first visit to be when they're in pain or when something's happened, because then it's all downhill, uphill. So the goals are just really to get them comfortable coming to the dental office, especially if parents don't have a good relation with dentists in the past, and we don't want their anxiety or their concerns to weigh on or to be passed on to the kids. So we want them to be comfortable with us. So it can be as simple as the first visit for a kid, they come in with their parents, and they watch their parents visit, they watch their parents cleaning, and then afterwards we do what's called a knee lap exam, where they just kind of lay the kid back in our lap, and we just kind of take a quick glance. And that way they don't see us as a big scary people, and then we'll just kind of earn their trust from there. But those visits are just as important to the parents as they are to the children, because we have to explain the importance of baby teeth. So even, yes, you're going to lose them, or you'll lose most of them, but they're space holders, and that's very important for the normal growth and prevention of crowding and other dental issues going forward in the future. We also allows us to evaluate the growth and bite, and so we can fix things early on before and play with children's growth as far as their bite concerns, if we can catch things early. The worst thing it would be to catch things late, because once that suture fuses in the midline of their hard palate, then to do major changes would require surgery rather than just something simple like an expanding retainer. Also look for oral habits such as thumb sucking, anything that we can, because if you can stop those early, they can actually go back and not require any intervention, and the body can take care of itself. But it's amazing what the musculature can do on a growing mouth. And then in our office, and we consider pediatrics 18 and under, or excuse me, under 18. So we're looking at the plaque that's accumulating on their teeth and then teaching them how to better keep that clean. And so we actually have stain that we can put on teeth that will show you, what's new plaque and just maybe missed from the last day, but also what's 48 hours or older. And that's usually what leads to decay or other related issues with the gum tissue as well. And then so adult oral health, and so that for us is 18 and older. And so what we're really doing there is we've already kind of, we're continuing everything that we've taught them on younger, but also adding in periodontal health. And what that includes is checking the surrounding structures, because it's just, and I always use the comparison to the most important part of a house being the foundation of the house. Same thing with the mouth. It doesn't matter how nice your teeth are if the foundation or the gum and bones around it are not doing well. And so we take measurements of the gum tissue to see the depth of that, to make sure that you're not losing bone, and teach you how to properly take care of your gum tissue as well as your teeth. We do an oral cancer screening. We're doing that in the pediatric visits as well, but we don't really see too much smoking below 18. But when people have more habits as they get older, it's more likely to occur. We also do a jaw joint exam to try and screen for any kind of clenching or grinding, and we're also seeing that more in pediatrics as well. I think more and more you're seeing dentistry go into the realms of sleep apnea, and I'll talk a little bit about that later. But if a child's clenching and grinding their teeth at night, then we're concerned maybe they might have an airway issue as well. And so looking at the size of their tonsils and adenoids and things like that. We also go through the main causes of tooth loss with adults. And so besides trauma, those would be decay or cavities, periodontal disease or bone loss around teeth, and then also bite-related problems. So if somebody's continually breaking teeth down, like I said, don't just fix the tooth, look for underlying problems and causes of that. And then we also get into prescriptive radiographs. And so we don't just take x-rays on every patient just every year because that's what their insurance will pay for or anything like that. And so with dental radiographs, there's three main ones that we'll use. And so bite wing x-rays, this allows us to look at the bone levels in between teeth and also to check for cavities between teeth. And then we also can see around their existing restorations. And for this, we typically take those if they're a high decay risk. Sometimes they can be every 6 months or a year. If they're a low decay risk, it's usually every 2 years. You can also take up close pictures like this of individual teeth and their roots, or you can take what's called a panoramic X-ray. And that allows us to evaluate the wisdom teeth, see how they are, if they're there, where they are, and how they're coming in. It also allows us to see the apices or the ends of the roots of teeth to check for any kind of pathology. And it also allows us to see if there's any pathology in the mandible or to check the sinuses for anything of concern. And now what's really become big in dentistry is that we have 3D capabilities in office. And so with this, we can take cone beams or cone beam CTs And this is just great for if you can't really see a fractured tooth in 2 dimension, but in 3, we usually can. It also allows us to plan out certain surgeries. So if we're placing implants, we can see the exact width and depth of bone. So we're not getting close to any kind of vital structures like nerves or blood vessels. So we can take a lot of the guesswork out that we used to maybe miss in the past. And then going into geriatric oral health. And so the main thing you'll see as patients get older, they're usually on more medications, and those medications have side effects. The main side effect for dentistry would be that it causes a lot of dry mouth. And dry mouth increases, saliva is your body's natural defense against decay. So if you don't have that, we see skyrockets in the amounts of decay. Also, as people get older, they lose their manual dexterity. And so that decreases their oral hygiene and how they're able to take care of themselves. And then we get into something called, terminal dentition. And so that's where, everything in dentistry fails. And our ultimate goal is to have things fail as slowly as possible. But, it comes a point where somebody can't keep up with it. You're just trying to keep people comfortable. Here's another quote. So success is never owned, it's only rented, and the rent is due every day. So constantly strive to do better and keep up with everything. So acute dental problems. And so the main things that we deal with obviously are tooth pain. And so if you think back to that internal anatomy of a tooth, when something gets to that nerve tissue, whether it's through decay, whether it's through fractures or trauma, that's kind of what we need to do. If it's through decay, usually the tooth can die, and that was what would lead to infection. And then infection leads to swelling or an abscess down by the end of the root. That can lead to some pretty substantial swellings. And so if anything's localized, the best thing to do would be to either get the infected nerve tissue out of the tooth or to have the tooth removed itself. When something's localized, antibiotics are usually not the go-to unless you can't do anything that day. But definitely localized can turn to a systemic infection pretty quick if not managed. And that's when we tend to use antibiotics and if that's not taking care of the infection, then that's when they go to the ER, an oral surgeon. And then trauma, we usually have to dictate if it's a hard versus soft tissue. And so hard meaning damage to the teeth or the bones in the mouth, and soft tissue if it's into the gums or into the face. We've seen dog bites, things like that. I'm not trying to be a plastic surgeon, so if it gets anything substantial, they go to the hospital. And so some of the procedures we'll do in dentistry, and I'll kind of run through this fairly quick, but restorations are what's commonly termed as fillings. Crowns are what's commonly termed as caps, root canals, extractions, implants, dentures, and orthotics. So restoration. So basically what we're doing when we do fillings is there some reason for the filling? And most of the time that's decay or a bacterial infestation of the tooth. And so we'll go in there, we use a high-speed handpiece, we'll remove the decay, and the success or whether that restoration or filling is going to become sensitive is how quick you got to it and how close that decay or the restoration is now going to be to the pulp tissue or the nerve. We can also do restorations to prevent decay, and those are commonly referred to as sealants. And so when we go back to that external anatomy picture of the tooth, all those deep grooves and pits, we like to clean those out and seal those up with a tooth cover material to make them glassy smooth. That way, that's the most common spot to get a cavity. If we can seal that up, it helps them out, especially in a younger age. Replacement of tooth structure. If somebody's fractured a tooth, we can usually build that back up. Protection of the pulp, going back to a fracture or decay, if you can get more of an insulated layer, they're less likely to have sensitivity or any kind of pulpal inflammation. And then to restore back to function. So that usually is included in people that have worn a lot on their teeth, and sometimes restorations are not the best for that. So then you go to crowns. And so what a crown is, it's basically, majority of them now are porcelain, and and it's just a full tooth replacement. And so we reduce the tooth enough to allow for adequate thickness of porcelain all around the tooth in the various areas, especially in the stress-bearing areas. We need a little more porcelain than others. This is more of a longer lasting restoration than fillings. And they can also be used as a tooth replacement. You know, before implants, this was kind of the go-to, is to do a bridge. If you think of Hollywood smiles, it can be just for aesthetic purposes too, with what a veneer is just a partial crown. And then in heavy wear cases where they've worn down a lot of their teeth, if you're trying to open them back up, that's usually done through crowns. A root canal. So when decay gets to the nerve and a patient either has pain that has gone to the nerve tissue, and then if it's irreversibly damaged or inflamed, that's when a root canal needs to be done. Now, root canals have a bad rep too, just like most things in dentistry, but the pain that people associate with a root canal is not the pain of the procedure itself. It's usually the pain that leads up to the procedure. And so the procedure itself should cause no pain because you're numb. And that's where they go in and they remove either the really inflamed nerve tissue or the dead nerve tissue, and then clean it out and then fill it back in with an inert material that allows you to keep the tooth. The tooth will have no sensation, but you keep your proprioception. So your body still recognizes it, but it just won't have any kind of feeling to hot, cold, or anything like that. In worst case scenarios, if there's not enough tooth structure, then we'll remove teeth. And so now with the implants becoming more and more the standard of care and popular, and when we remove teeth, we often are grafting that site with a bone graft or anything like that to keep the width and height of bone so they can have a future implant, because the body has no reason to keep bone in the mouth if it's not to hold teeth. And so that's kind of unfortunate for people, especially if they have to go to dentures and things like that. But the body resorbs bone, so you'll see bone get thinner and shallower after a tooth extraction. And so going to implants, and so an implant is a titanium screw that's placed into the jaw, and they're just great for tooth replacements because yes, you don't have the proprioception that you would have with a root canal. So root canal is usually the first standard of care if the tooth is salvageable, but if there's not enough tooth structure, then an implant can be placed. And what's neat about them is they just fully integrate into the body. So there is a direct connection between the titanium interface and the bone called osseointegration. And so that takes time. So they're a little longer of a process. So they have to be placed into the bone and then healed for a while before they can be loaded. But the nice thing about implants is they don't get decay. They don't get cavities. So the main things you have to do are worry about the bone around the teeth. So same thing with periodontal issues. You got to make sure that they're able to keep it clean, but then also not overloading it so that you don't get stress fractures. And then when all else fails, if the dentition is too far gone, then there are teeth replacements like dentures. And so now, especially with implants, we can do where we just mount dentures to implants, and so you don't have to have necessarily a removable option. And even you can have removable ones that are cleansable and still attached to denture or still attached to implants. And then orthotics. And so for many, this might look like a night guard, but really what it is, you know, they have boil and bite night guards you can get from any kind of convenience store or anything like that. But those are just a flat plane that really just have you biting on your back teeth, or they're really soft like a sports one that can actually, if you're a clincher like me, they can actually encourage you to clench your teeth more because now you have something to chew on at night. But a bite splint is, you know, it fits over your top teeth and it's more for protection. And oftentimes that is what will satisfy TMJ issues. And we'll get to that here in a little bit. But also we have orthotics, the same thing, they hold teeth in place. And so some of you may have had ortho in the past and saw your teeth shift. And so we have something that everybody will experience called late mandibular growth, where our jaw continues to grow, teeth shift, and then what was your straight teeth are now crooked again. And so these can help hold teeth in place. And then, as we talked about a little bit earlier with sleep apnea, one of the main things in dentistry is after a patient has a diagnosis of sleep apnea, and usually for a dental orthotic, it needs to be more of a mild to moderate case, we can make what's called a mandibular advancement device. But basically, it pulls their lower jaw a little forward and opens up their airway. And that usually can get some good success, especially if a patient's not compliant with a CPAP machine. Sometimes those take a little bit to get into. This is a little less obtrusive. And then they can have a follow-up sleep study after we make them an appliance, and then to see if it really is giving them improvement.
Dr. Arthur,
Yes.
can you tell me again what that device was that you make if they're not compatible with the CPAP?
So it's the actual device, if you want to look that up, is called a TAP3 appliance, but the general broad spectrum name, it's a mandibular advancement device. So it just basically is pulling the lower jaw forward. And so here's just another funny quote if we got any Office fans. And so it's not really it's a quote, but just for fun. And then oral facial pain. And so this can be, if you are able to add this into your practice, this can be a major practice builder and get you patients for life, because oftentimes these patients have seen numerous different doctors, physicians, dentists, and can't come to a cure. And sometimes they have to go to see oral pain specialists, hence why there is its own specialty now. But this involves the diagnosis, management, and treatment of pain disorders in the jaw, mouth, face, head, neck. The first thing we always want to do is rule out if it's actually a joint problem, if it's a muscle problem, or if it's a neurologic problem. And so oftentimes they are musculature problems. And so if somebody clenches or grinds their teeth at night, some of the main muscles that are involved in the opening and closing of the jaw are the temporalis muscle and the masseter. And so when people feel this, if they've had headaches and they wake up with headaches, they wake up with neck aches, which can be accessory muscles to clenching and grinding, making them a bite splint is, the least invasive, most simple way to do that. And if that can shut off everything, because at night we can put 6 times the amount of force on our teeth as we can during the day. So if we can shut off those muscles and keep them from firing, oftentimes, we can help people have a reduction in those symptoms. There are rare neurologic disorders in the head and neck that we refer out to if we think we've encountered one of those. And then also joint issues as well. If you make them a bite splint and the pain gets worse, then you always screen for that ahead of time to know that you're not overloading the joint back here, which has a disc in between it. And there's no nerve tissue in the disc except on the back side of it. So sometimes if people have slipped their disc forward, and so you might have friends that have popping when they're open and close, or you might hear, sometimes you can hear those people when they're chewing. That's what that is, the disc sliding in and out of place. And so if they're on that back tissue, then that's going to cause pain as well. And then this is kind of a major topic in dentistry, and where it might tie a lot with medicine as well. And I think the very bottom where it says your mouth talks to your body and your body talks to your mouth. And so there are a lot of kinds of potential facts. And I think the major thing you guys will learn is to recognize causation versus correlation. So you got to understand if there's just maybe a connection between two things, or if there's actually a direct, A causes B, or if just oftentimes you'll see in people with A, you often see with B. But what we do know is that the bacteria that's in your mouth has been cultured all throughout the body. So if you have inflammation is systemic. It goes to your bloodstream, which can carry out to all the other organs of your body. And so if we can decrease the amount of inflammation, we can improve overall health in general. And so we strive for, when we check gum health, we can give them an objective score of the inflammation that's in their mouth. And so we check every tooth, the gum tissue around that, and we check for bleeding. And so that can give them an objective score. And patients love to find out what % they are, because it's it's a competition between husband and wives. It's a competition for people that just want to be healthy in general. And so our ideal goal is to get people 95% healthy or above. And so we'll track on when patients come to our office. And so we have a couple ways we welcome patients into our office. We have patients that are just coming from a previous office, and they've been regular for a long time. And so we find that the average score of one of those patients that comes in is about 80%. But if we can track something, I don't know if you've ever heard the quote, if you track it, it will change. So if you track that and you can tell somebody what their health score is and how to improve that, then you'll see it drastically change. And the nice thing about gingivitis, or just inflammation of the gum tissue, is it's reversible in 2 weeks. And so if you can get whatever's causing that, if you can get the tartar, the plaque, everything off their gums, then they can see an improvement in their inflammation in 2 weeks. And then we also have patients that have never been to or haven't been to the dentist in 5+ years. And so the average person that comes in that way is looking at around a 60 or 65% health. And so those are where you actually see absolute drastic changes in people, and they buy in and they understand, and it's a much more fulfilling way to treat people rather than just respond to crisis situations, is to be preventative. And that's what dentistry is, very preventative. So the types of dental practices, and so the different models that we see are now, there's a lot of corporate dentistry, and that's probably as close to what you could think of as an actual hospital, a dental hospital without being in a hospital. They're usually larger facilities. They'll have multiple through the areas, and they're just high volume clinics. You'll have federally qualified health centers, and that's what FQHC stands for. Those would be more, they accept everything, and they also are big Medicaid and Medicare providers. I've had the experience of working with 2 in rural areas, and so sometimes they may be the only clinic in the area. And so they're a good source of, because they have a lot of access to care. They're also usually very high volume clinics as well. And a lot of it is you are responding to crisis situations. I think one aspect of that in dentistry that we could do better in some of these areas, and probably in medicine, is education in general. And when you have high volume, you don't get a lot of time to educate. It's more of treatment rather than education. And so oftentimes you might treat something and then in a couple of years have to treat it again. There are dentists and dental offices within hospitals, and sometimes those might include actual residencies, so specialist residencies, oral surgeon residencies. And it is nice when there is a dental aspect to a hospital, because you can look up different statistics, but the highest I've ever seen one state is that close to, in some hospitals, it was 10% of emergency visits were some kind of dental related. And so you're very limited at what you can do in an ER with somebody coming in with some kind of tooth pain, besides prescribing antibiotics and pain medications. And so without a dental capabilities, then yeah, there's not much you can do except send them to a dentist. And then you can teach in dental schools, and so oftentimes dental schools will have faculty practices within there, or there's residencies as well. And that would be where you go into specialties, or you can do general dentistry residencies like I did. And then private practice. And so it's becoming less and less as more private practices are being bought out by corporate. But for me, that's been a very rewarding shift in my career, because I can set my schedule how I like and be able to educate more and spend that time. And what we will refer to as more of a relationship-based practice. And so that's where you really build, makes the career more rewarding, but also patients become your family. And so that's definitely been an improvement in quality of life and quality of care for me. I think the Air Force gave me, and if any of you have interest in the military, not just for the financial gains as far as school has skyrocketed in cost, but for me, the military always placed a heavy emphasis on quality over quantity. And so my schedule actually in the Air Force is pretty similar to what my schedule looks like on a day-to-day here, where I set aside the time to do it right, and or have the time to do it right, educate so we don't have to do it again, things too. And inevitably you have to redo stuff, and not all patients listen, but it just makes it I feel like it's how it should be, and I hope everybody could have enough time to educate both in dentistry and in medicine. I have a sister, she's a physician in family practice physician in Oklahoma City, and she just started her own practice. She started private practice, which I feel like is pretty rare now, but she left the hospital setting because she was told to spend 10 to 15 minutes per patient, and that just wasn't what she wanted to do. So I respect her, but she also is pretty hard on her brother for being just a dentist, and she's one of those ones that calls me a fake doctor and everything like that. So she's great. And then the last thing, and probably just as important as everything else, if you've learned anything in this lecture, is continuing education. Everybody in here, whatever career path you're going to follow, you're going to be lifelong learners. And so I put this in there. It's required, but it's also required. So not only is it required to keep your license, but it's required if you want to just do the best for your patients. And so the one thing that definitely was not on my radar that has been my biggest transition in my continuing education was I had always looked for the technical aspects. So how can I do newer procedures? How can I do them better, faster, last longer? And that's important and that's great. But there's so much out there as far as communication and philosophy. And so how you want to practice and how you want to, talk to patients. So get patients to say yes to ideal treatment and to say yes to getting better, not just the quick fix and just to get them out the door, to have them understand the importance of dentistry, the importance in their overall health. That's been huge for me. And it also correlates to your life outside of the practice. Do you want to get burnt out? And that's the burnout is real if you have a high volume. Or do you want to have more energy when you leave for the day and spend time with your family? And so that comes to why. So why do you guys want to do this? And so why I do it is you'll find your why in everything you do. And so patients, it might be your 10th patient of the day, but to them, you're their only appointment of the day. And so just remember that every patient you see, that's going to be, and how I look at it is that's somebody's Emily, that's somebody's Lucy, and that's somebody's Graham. And so they deserve my very best every day. So it truly is a privilege to care for another human being, and that's a sacred trust. And it's one that's well worth it, and it takes a lot to get to that point. And obviously you can see I'm a little passionate about it. Here's my quick references for all the Google images I stole. So I'll put it really small so you guys can't see where I got them. And then thank you very much for your attention. I'll leave you with one more quote. From everyone who has been given much, much will be demanded. And from the one who has been entrusted with much, much more will be asked. And so you all have tremendous talents and you're going to work very hard. So continue to do so. And the way I look at it is, to whom much has been given, much is expected. And so I wish you all the very best in your future careers. Thanks for your attention on this Friday at lunch. I'm sure this is where everybody wants to be right before the weekend on your lunch period. So thanks for spending it with me. And so I got plenty of time for questions if there are any. And I do have the advantage of Zoom, so I can look it up, or I can act like I'm frozen if I don't know the answers. So.
Oh, Dr. Arthur, thank you so much. How true that quote is, and I think that was very useful information. I've certainly learned some things, which is great. Does anyone have any questions?
How would I see the chat? If there is there any, or you can, I guess you can just read if there's anything on the chat.
I would go ahead if you want to stop share, then oh, Marcy just concur. Yeah, wonderful presentation. Yep.
Hi, I have a question.
Sure.
Sorry, my screen isn't working, so you're not going to see my picture. But thank you for the presentation. I'm actually going into pediatrics. So do you have any pearls for like acute pediatric trauma about teeth that I need to know about?
Well, I mean, I guess like I said, that's the worst dental visit I could probably think about is somebody a kid that's never been to the dentist, and then comes in with some kind of pain or problems. Um, I guess it would really depend on what trauma is inevitable, and that's something you can't prevent. Oftentimes, you can just do kind of palliative care and get them comfortable, especially, and you're going pediatrics as far as medicine, right? None of you guys are dental school or anything like that, right?
Correct.
Yes, and then as quick as you can get them into a pediatric dentist, and they have all the tools and tricks to sedate kids and get them to sleep. But you can do a lot just to keep kids comfortable. And oftentimes, besides straight, let's see here, primary teeth have different rules than adult teeth as well. So we can reimplant adult teeth, but if a baby tooth comes out, it stays out. Because the main thing is you don't want to have any kind of issues with messing up the permanent dentition. You can handle antibiotics and things like that. You can get kids pretty comfortable with a little bit of Tylenol can go a long way too. But yeah, I mean, I would just say you're limited at what you'll be able to do. So a good pediatric dentist on hand would be important. And oftentimes, because even in our town, hospitals have pediatric dentists on staff, and so it's nice to be able to use that tool. And they're, like I said, they're the saints of dentistry, and so if you can pretty much call one of them at any hour of the day, and they'll help you out too. I know that's kind of not the best answer to the question, but
No, thank you. I'll make friends with my pediatric dentist.
that would probably be the best thing I would say if you get from that. So. And to be honest, they should reach out to you too. And so that's nice to always have a referral back and forth, because they'll send, you would be a good referral base for them, and vice versa. So, I definitely would say having, and even me as a general dentist, knowing the ER physicians, knowing ENTs, definitely knowing all my specialists, because my patients, if they're in pain, I will see them that day. And, that philosophy is passed on to who I refer to as well. And they're great at the sense of if they will get them in that day or the next day. And it's not anything to brag about. It's just the relationship that I formed with them, and the mutual trust. And, they know that they always are. They say our patients will live and die by what we say. And so I take that to heart, but I want to make sure that they know that they're going to be taken care of too.
Thank you.
Mm-hmm. Anything else?
Well, I'm sure not seeing anything in the chat, so I would say we're good to go.
Okay. Well, and also you can pass along my email if anybody wants to send out a question or anything like that.
Perfect.
I was always the shy. I never asked questions either, but I'd always ask afterwards. So if anybody, don't be shy. She'll send you out my email if you have anything, and
very good.
Or just search Google. So.
Well, thank you so much. We really appreciate it, and I hope you have a great weekend. And
you as well.
Yeah, thank you for your time today.
Take care.
Okay.